kidney care, and it follows on from our successful series of mini workshops that we undertook before Christmas, looking at the practical implementations and delivery of remote kidney care and issues related to the lived experience of kidney care, receiving it remotely, and also equality, diversity and inclusion. So next slide, please, Julie. So just by way of a brief introduction and a little bit of housekeeping for you, this webinar will be recorded and shared with all of the participants and placed on the KQIP website in due course, where it will be completely freely accessible to all. During the webinar, please feel free to post your questions and comments in the chat box. Please try to remain muted during the sessions and use the raise hand facility if you have a question in the reactions box at the bottom of your screens on the Zoom. Please post any technical issues in the chat box and we will try to resolve these as quickly as we can. Sometimes information technology can be a proper nuisance, and if your signal is poor, please try logging in again or back out and back in again. Try using your headphones and please don't forget to mute your microphone. Next slide, please, Julie. So today I'm delighted that we're going to be having the findings from our National Survey for Patients and Healthcare Professionals that Hannah Young and Courtney Lightfoot will be presenting to us, and they're focusing in on key aspects of the findings from that survey, looking at remote kidney care. We'll then move on to two discrete sessions. First of all, looking at how we should equip healthcare professionals to optimise communication in remote kidney care. I'm delighted that we've got three superb speakers to take us through that session. And I'm also very grateful to one of my co-chairs, Andy Henwood, who's the co-chair of the Kidney Patient Involvement Network, who will be joining us to chair session 2, which is the importance of keeping patients informed and involved in important appointments and care decisions. So that's our agenda for today. And so moving on then, Julie, please, to the next slide. Without further ado, it's my real pleasure to introduce you to Hannah Young and Courtney Lightfoot. Hannah is a research physiotherapist at Leicester Hospital, and she's also the Vice President of the BRS in clinical development. And Courtney Lightfoot is a research associate also at the University of Leicester. So without further ado, over to you, Hannah and Courtney, and thank you very much for presenting your findings to us here today.
Good afternoon. It's a real pleasure to be presenting these results to you today. As Antonia's just said, my name's Hannah. I'm a renal physio and an NIHR fellow from University of Hospitals of Leicester, and I'm also going to be presenting alongside my colleague, Dr. Courtney Lightfoot, who's a research associate at the University of Leicester. And we're going to be talking you through today the results of a national survey for patients and healthcare professionals relating to remote kidney care during the pandemic. I'm going to present in two parts. So I'm going to discuss the results from the patient participants, and Courtney's going to cover the results from healthcare professionals. Next slide, please, Julie. So prior to COVID-19, remote delivery of healthcare enabled by technology in all its various guises was patchy. And a Health Foundation report found that uptake across patients of all ages was quite variable. And COVID-19 has obviously led to the introduction of remote care at scale and pace to reduce requirements for face-to-face contact. But this rapid introduction into renal services meant that patients and the workforce have not been fully prepared or equipped to get the most from their interactions. We now have an opportunity to step back and to consider how we best utilise remote care in renal services. And by exploring patients and healthcare professionals' experiences of remote healthcare during the pandemic, and their perceptions of how it might be used in the future, we have a great opportunity to identify areas of good practice and opportunities to capitalise on and to reflect on areas for improvement and change. Next slide, please, Julie. So this study was part of a much larger observational study called Dimension KD, and we explored the impact of COVID-19 on kidney care. The study was conducted online between August and December 2020, and we recruited participants from 11 renal units across England. Patients were eligible if they were over 18 and had CKD stages 1 to 5, not receiving dialysis, or they had a transplant, and if they were able to give informed consent. And healthcare professionals had to be over 18, again, able to give informed consent and be providing care to people with a kidney condition. Both questionnaires, we gathered demographic information such as age, gender, ethnicity, and we also asked for information on their experiences of COVID, the impact of COVID-19, and their experiences of healthcare, including remote care. And these questions were developed from World Health Organization COVID survey, but also bespoke questions that we developed with the UHL renal team and within the Leicester Kidney Lifestyle team. For patients, we also gathered information on health status, and for healthcare professionals, we gathered information about roles and responsibilities. And today we are just going to focus on the results relating to remote care. Next slide, please, Julie. So we had 549 patient respondents. Over half of those, just over half of them were male, with a mean age of 60 years old. 55% were transplant patients and 45% non-dialysis CKD patients. And 93% were white British, which is obviously a noted limitation of this survey. The experiences of people from other backgrounds and cultures may be quite different. But what we did find, if you can have the next slide, please, Julie, is that prior to the pandemic, only 11% of respondents had actually had a remote care appointment. And this was primarily on the telephone for triage or to follow up and discuss test results. During the pandemic, this unsurprisingly increased, and 77% of respondents had had a remote care appointment, which represents an increase of 489%. And the majority of those who had had a remote care appointment would have another. Next slide, please, Julie. And of future appointments, 60% of those that were scheduled were due to be remote. And of those without a planned appointment, over half wanted it to be a remote appointment. Next slide, please, Julie. So the strengths of remote care for patients included increased efficiency. They were able to better time their appointments around recent test results, which enabled them to have more up-to-date and relevant discussions with their healthcare team. A noted strength of remote care was that less travel was required. So particularly among patients who were dependent on others for transport because of disability, that was an important strength. And it reduced stress associated with travel and saved patients both time and cost. I'll just give you a second to read some of those quotes. Next slide, please, Julie. These positive experiences were fostered by established partnerships and relationships that pre-existed with the kidney care team, and this rapport made communication remotely much easier. And it was also aided by preparation on the part of the patient prior to the appointment. So again, having access to up-to-date results in advance of the appointment helped them to anticipate what would be discussed, prepare questions, and get the most from their interaction with a healthcare professional. Next slide, please, Julie. But there were some noted weaknesses as well. Clinical assessment, patients found much more challenging because they felt that the kidney team were reliant on their description of their condition or their symptoms. They felt that remote care was less responsive to emerging problems or issues, and often they had a feeling of being rushed or not listened to. And therefore, the level of care was not felt to be equivalent to face-to-face, despite its greater efficiency. I'll just give you a second to have a read of those. Next slide, please, Julie. And these feelings were enhanced by some notable barriers to remote care, particularly communication difficulties amongst those patients who had sensory impairments. Patients found it quite difficult to build rapport remotely, and there was a perceived lack of confidentiality with online appointments. And subsequently, patients felt that it was difficult to be honest and to disclose particularly challenging and emotive issues. And they found it much harder to articulate their problems during a remote care appointment. Next slide, please, Julie. But there were many opportunities for the future. So generally, patients felt there was great potential for remote care to continue post-pandemic, but perhaps delivered as a mix of both face-to-face and remote appointments that was led by patient choice and patient need. And they described preferring a face-to-face appointment when there were changes in kidney function or overall health status, when they wished to discuss something which was non-routine. Next slide, please, Julie. And face-to-face was also preferred when there was a need for physical assessment, and patients also thought it was important to have face-to-face contact at a regular interval to develop and maintain a rapport and a relationship with the kidney team. And next slide, please, Julie.
Thanks, Hannah. So in terms of the healthcare professionals, we had 59 respondents. Over 70% were female, with a mean age of 44 years. Majority of them were nurses or consultants or specialist registrars, and 64% were white British. Next slide, please, Julie. So 76% of participants reported using remote care for patient consultations that previously would have been face-to-face during the pandemic. And of those, 89% used them for outpatient appointments, and 51% of participants used them to assess patients' needs when they reported a health problem. So in terms of the methods that were used by those people who used remote methods, 96% reported using the telephone, over half reported using email, and just over a third reported using video methods. And 36% of staff reported that patients declined remote care appointments. Next slide, please, Julie. So in terms of their remote care usage, 86% of those who continued using remote care methods in the future, particularly in terms of using them in combination with face-to-face appointments. 7% were unsure about using remote methods in the future, more so for safety reasons, as they felt that they couldn't assess people properly virtually and would prefer to do it face-to-face. And 7% would prefer to return to face-to-face appointments. For similar reasons to those who were unsure, they felt that virtual appointments had more limitations than benefits for patients, and found it difficult to assess people virtually than they did face-to-face, and believed that it could compromise care. Next slide, please. So in terms of the strengths of remote care, healthcare professionals felt that it reduced the burden on patients, particularly in terms of travelling to the hospital, in terms of time saving for them and having to wait in the waiting room. And healthcare professionals also felt that there was reduced work pressures using remote methods, as it enabled them to see a wider variety of patients, and enabled more staff to be on site to provide multiple clinics for people. And also there was less need for resources, so in terms of not needing a clinic space, and they could be conducted anywhere within the hospital that had a computer trust login. I'll just give you a moment to have a look at those. Next slide, please. So in terms of the facilitators to deliver remote care, staff felt that they provided effective communication, as long as this was constant and accurate communication between the team. And they also felt that it made them pay greater attention to how they communicated with other staff members. They also felt that it enabled more thorough assessments of patients to be conducted with fewer disruptions. And also having appropriate systems in place, such as drive-through phlebotomy services and follow-up procedures and protocols, enabled for people to be followed up adequately and things weren't missed. Next slide, please. So in terms of the weaknesses of remote care, it was considered that staff were unable to have the same discussion with patients that they would be able to face-to-face. This was mostly due to the fact that they felt patients felt that they needed to be seen or assessed to discuss important decisions. And patients were considered not to disclose all of their issues remotely, which led to patients becoming unwell and actually being admitted to hospital. And it also led to lack of effective monitoring and patients starting dialysis earlier than they expected to. And as a result, it led to potentially delayed interventions as issues were not being resolved or monitored appropriately. And another weakness that staff highlighted was the inability to detect non-verbal cues and overall appearance of the patient. Next slide, please. So in terms of the barriers to deliver remote care, the difficulties in communications was the predominant theme that came from our findings. And this was mostly due to patients having hearing difficulties or memory problems or a non-English speaking, which made communication difficult. And also patients felt that they could only communicate to the doctor or clinician face-to-face and show them their symptoms. So I'll just give you a moment to have a look at those. Next slide, please. So in terms of moving forward and the future of kidney healthcare beyond COVID, healthcare professionals felt that there was a place for remote care, particularly in terms of patients who were considered to be stable. And they felt that remote appointments would be appropriate for those who don't always need to be seen face to face. Also, delivering remote appointments would increase the flexibility in appointments and provide options to patients about how they're managed. And a lot of this came with an alternative approach to having both face-to-face and virtual appointments, which would enable to have a more multidisciplinary team approach. Next slide, please. And in terms of the mode in which appointments were delivered, healthcare professionals should believe that this should be patients' choice, and we should empower patients to give them greater control and better access to their health and their healthcare. And also having appointments for triaging, so triaging patients to find out what type of appointment they needed, as to whether they would come in to face-to-face or have a virtual appointment. And also redesigning services was believed to facilitate future healthcare. So setting services up in a way that would enable hybrid appointments to take place and the flexibility to move between face-to-face and remote appointments. Next slide, please. So we've just tried to pull together the results of the patient and the healthcare professional surveys and try to highlight the strengths and weaknesses, opportunities and threats that are posed to remote care and the delivery of remote care in the future. So in terms of strengths, there's increased efficiency in delivering remote care. Also, there was time saving for both healthcare professionals and staff, for patients and staff. There's also reduced travel for patients coming to face-to-face appointments. Also reduced stress for both patients and healthcare professionals, and more opportunity for other roles. In terms of weaknesses, it's been identified by both patients and healthcare professionals about the communication challenges, particularly in terms of disclosing issues or problems or symptoms, and also the lack of honesty in terms of how people are actually feeling and issues that they are trying to manage. Also, there are concerns around the assessment accuracy of assessing people or assessing patients virtually. There's issues around confidentiality and perceive that there's a lack of confidentiality by patients using virtual appointments. And there is perceived reluctance from both patients and healthcare professionals about going all virtual in the future, and there's a need to have face-to-face appointments. And some patient groups are disadvantaged. As Hannah mentioned at the start of the presentation, our sample was predominantly white, so there may be issues in other cultures or ethnicities that we haven't highlighted, so there's definitely some future exploration with that. There's opportunities to use remote care more routinely in the future and to support face-to-face appointments, so having a hybrid or face-to-face virtual appointments as a follow-up to face-to-face appointments. Also, remote care appointments were considered particularly useful for a specific group of patients, particularly those with stable disease. The threats to remote care is the loss of information gained from virtual appointments. Also, this perceived lack of skill to manage patient appointments remotely, reduced resilience by staff, mental exhaustion from staff, also difficulties in referring to other services virtually, and the fragmented care and coordination between specialties. Next slide, please. So we've just kind of pulled together some change ideas or areas of improvement based on our findings to how we can move forward and deliver better, high quality remote care in the future. So triaging was highlighted as one of the key findings, and using this to identify patients who need face-to-face appointments. So having that system in place will allow kind of direction as to which appointment type that patients will need. Also, there's a need to develop communication skills to deliver remote care effectively and to engage patients in disclosing more information. Also, changing process to enhance and monitor patients that may be at risk. And also to develop techniques to recognise and manage remote care fatigue. And I really like this quote about how we can move forward with remote care, that there needs to be better systems in place and consistent, reliable platforms and high quality electronic records and digital access. So these need to be in place before remote care can be delivered effectively and sufficiently in the future. Next slide, please. So I'd just like to thank the rest of the Leicester Kidney Lifestyle team that were involved in the study. Also the participants, the patients and healthcare staff who took part in the study. Also the researching teams at all the participating sites, and the KCOOP team for the opportunity to present our findings today. Thank you for listening, and we'll take any questions.
That's fantastic. Thank you, Hannah and Courtney, for such an excellent talk and overview, and what a rich source of data and set of data from an extraordinarily rich multidisciplinary team that you've got. Are there any questions from people who are participating, our delegates? Any questions from the floor? Speak up now if you do. Fiona Loud, your hand is up. Away you go.
Thank you very much. Yes, a real quick question. Thank you very much for the very interesting talk. Interesting how it reflects on some of the things that we've heard at Kidney Care UK as well. Absolutely. But one thing for you, did you get much through on COVID anxiety and COVID safety from, oh, there you are, from your recipients, respondents rather?
So there is quite a lot of data at the moment. We're also doing a follow-up. So I think we're waiting for the follow-up survey and to get the findings from that before we analyse it in detail, to try and find out how people are now, because obviously I think everybody was anxious during the pandemic. So it'll be interesting to see how things will move on in the next few months. So yeah, so we're just collecting that data at the moment. So yeah, there will be findings coming out at some point with regards to that, because we do have data at the moment, but I think it will be supported better by how things are at the moment.
Lovely, thank you.
Comparing to last year.
Yes, indeed. And one other really quick reflection, if I may, is that the system that has been built was happening anyway, but it had to be built very, very quickly, seems to have been built around healthcare professionals and around existing systems than around patients, the recipients of that care. And certainly that's something that I would say, we would say, it needs to be looked at again. You can't rebuild it because it's already there, but you can certainly re-look at it from the point of view of all possible users of the system. And I hope that we can take this opportunity to learn from that and remember the people who are receiving the care rather than just the convenience of the way in which it's kind of had to grow itself.
Most definitely. I think that's the thing, isn't it? Because we were kind of, you've just pushed into it. There's no time to really stop and think. And it's kind of, how do we react quickly? But yeah, there's definitely lessons to be learned and things to take away that can be improved upon. And yeah, definitely needs to be, as it was mentioned in our talk today and across in the findings, it should be patient choice about how this works in the future.
Indeed. Thank you very much.
Thank you.
Thank you, Fiona. And any other questions for the floor? I might add that in the chat, Caroline Anderson has written that there's national paediatric data on this from a study last year, which is currently being repeated and analysed. So we'll have to watch this space for that. Thank you for that, Caroline. That's super interesting. Anybody else with a question from the floor? If I may, just before we move on to our next speaker, Hannah and Courtney, how do you think you will go about addressing the fact that 93% of your respondents were white and British and predominantly men, although only 56% men, but nevertheless a predominance of men? We know that, and also, you know, I think you said 64% of your healthcare professionals were also white British, when we know that healthcare professionals are a far richer mix than this, even though I do accept you had a very broad MDT representation. What do you think you can do to enhance the take up, if you like, from people who are not going to respond to white, you know, who are not white British? How do you think you can address that?
I think it's incredibly challenging, and our sample is very reflective of all our other research that we do. So all our research that we do are predominantly white. I think it's mostly our fault. We're not very good at accessing other ethnic groups for one reason or another. We definitely need to try harder to engage these people. It's something that we did start to look at before COVID happened, and then COVID happened and we just kind of panic stationed and kind of lost that a little bit, but it's definitely something that we are trying to do moving forward and trying to improve on.
Okay, Hannah, did you want to add to that?
I think one of the ways that we can improve on this is to use the sort of pre-existing networks that are out there to make sure that the questions that we're asking are appropriate, and that the recruitment strategies that we are using are appropriate to sort of engaging these different populations. So that is something that we can definitely look at for the future, redesigning the questionnaires that we're using, and making sure that we have the involvement of PPI members from different ethnic backgrounds, different ages. I think that's going to be really important moving forwards and something that we're working on.
That sounds really encouraging, and thank you for that, because there is such an emphasis on diversity and inclusion, not just from religious backgrounds, of course, but also from different cultural backgrounds, age backgrounds, and different literacy backgrounds and health literacy. And this is something that Gert Randhawa talked about in his one of our mini workshops last time, the importance of engendering trust and enabling all groups to feel included, whatever their backgrounds and whatever their values. Well, that is such an excellent beginning to our session, and opens the floor quite nicely to our next talk, which is going to be from Sajida Yusuf, who's my friend and colleague, consultant nephrologist from the Royal London Hospital. It's a perfect time to follow on from your talk, Hannah and Courtney, because I noticed that 2 out of your 4 key issues were how do we triage and how do we communicate, and that's just the subject that Sajida is going to talk to us through now. She will be followed by self-care for healthcare professionals from Amanda Bevan and her team at the Canton Canterbury Hospital. And finally, from Tahira Mir, a cultural and health improvement officer from Bradford Teaching Hospital, who will talk us through how or certain techniques we can use to support Black and minority ethnic group patients in accessing and receiving remote kidney care. So without further ado, I will lean over to my colleague Sajida to take us through how we should triage and communicate in remote kidney care and her experiences and work she's been undertaking at the Royal London. Over to you, Sajida.
Thank you very much, Antonia. And thank you, Hannah and Courtney, for an amazing presentation as well. I wish I could directly follow on and talk about the triage and communication and have some real answers, but unfortunately, I don't. So what I'm going to talk about is a little bit about what we did and a little bit about what we've learned through the process of transitioning to kind of remote consultations. Next slide, please, Julie. So the context, as everybody knows, is that as of last year, we had to go wholesale basically to remote consultation. But there was a background in that there was a recommendation that around 25% of outpatient appointments should be expected to continue remotely. And the new national planning guidance says that steps should be taken to avoid outpatient attendances that are of low clinical value. And there's another part of the planning guidance as well that says that waiting lists should be used to identify and address disparities by equity and in the bottom 20% deprivation decile. So talking about inclusion, it's very much on the national agenda. And then July 2020's phase 3 letter highlighted that health inequalities must be considered as service restoration is planned, including in the development of digitally enabled care pathways. Next slide, please. So what happened at the Royal London was that there was an outpatient transformation group for the whole trust, and renal became the first pilot area for a kind of wholesale transformation to remote care. That doesn't mean that we didn't see anybody face-to-face, but we became the pilot for transition to video consultations. So our primary goal in transforming care was to continue to deliver high quality care with excellent outcomes whilst keeping patients safe. And our second goal was also that we needed to ensure that access to care was equitable. Next slide, please. I'm not going to dwell on this too much. This is a driver diagram that we used. So we did a lot of background research, and what we wanted to do was ensure that we wanted to, in the transition, reduce inequalities of access, process, and patient experience in our outpatient services, and also to try and use this transformation to reduce an avoidable difference in outcomes for patients. And this touches on some of the topics that have been brought up in terms of communication, waiting times, flexibility, and so on. Next slide, please. This is just a little bit of background about the trust. I'm not very good at pretty pictures, I'm afraid, but we have a very big service, which is a large geographical area over several sites. We have around about 1,400 transplant patients now, 1,300 dialysis patients, hemodialysis patients, 250 on PD. We have 700 in low clearance, but we think that's a significant underestimate. And then we have our general nephrology patients. Those patients come to a variety of clinics. So we obviously have the nephrology and the specialist clinics, access, transplant assessment, and so on. Before you get to the stage of coming to a renal outpatient appointment, we have something called a virtual kidney CKD service, and that is slightly different. This is more like advice and guidance to GPs, where GPs can ask us a query, and we can look at the GP record and write a response to the GP. It doesn't involve any interface between the clinician and the patient, but that's where a lot of our referrals come from now, but it's a slightly distinct entity. Next slide, please. So we thought about what our considerations were, and this is kind of partly based on speaking to people, partly what we learned as we were doing it, and touches on a lot of the stuff that Hannah and Courtney have talked about. So in terms of what we need as clinicians, we need clinicians to be engaged, we need confidence in the system, we need training on how to use the system, because this was video consultations we transferred to. Need to have trust that it will work, need to consider information governance issues, and we need to think about what this means in terms of flexibility and working from home. Does it give us the option, for example, of doing more clinics out of hours at times that might suit patients more? We thought about what patients needed, which is an explanation of what we're doing and why we're doing it. And that, you know, one of the key things and one of the key messages is that this is not about giving you worse care than you had before for our own convenience. You hear a lot of patients say, oh, well, I can't see the GP anymore. They won't see anyone. We wanted to be clear that that is not what we want. You know, we didn't want to kind of foster that belief in our patients that this is somehow suboptimal. As we've already discussed, flexibility to change appointment types as and when required, and then also a clear communication channel with the clinicians and with the services. The biggest challenge, though, the patients and the clinicians are the easy bit, but are the surrounding structures. So adequate admin, management support and resource, how this links in with community services, so things like phlebotomy hubs, other diagnostics, links with the CCGs, you know, blood pressure monitoring, urinalysis, and we haven't got all the answers to that yet. And then also the IT infrastructure, both at a trust level, a network level, and individual level, so patients and clinicians. And then the most important thing was, what are we going to measure and how are we going to measure it? How do we know that what we're doing is working and it's going, and we're doing it properly and we're doing it well? Next slide, please. So I thought through what we did. And the easiest is just to dump it all on one slide and then talk a little bit more about it afterwards. So at the Royal London, so this is not on other sites because this hasn't been rolled out to our other trust sites yet, so Newham or Whips Cross, but the Royal London, we looked at our outpatient area and calculated the safe number of patients that could be seen in our department during any one session, morning or afternoon, and how we could manage that patient flow. We calculated that there would be 20 face-to-face patients in the morning and 20 in the afternoon. So that, for nephrology, and then 20 in the morning and 20 in the afternoon for transplant and surgical clinics. So a total of 40 patients per session could be face-to-face. Now that is considering we used to have 50 patients in one low clearance clinic on a Thursday morning pre-COVID. That's a significant reduction in how many patients we could see face-to-face. We then reprofiled all renal clinics by default to be video clinics on our IT system. And we had completely separate clinic lists for face-to-face appointment bookings. We increased the time of video appointments to 15 minutes, recognizing that there are these issues and that it's a system that does require a little bit more admin. And we have a minimum of face-to-face of 20 minutes for a face-to-face follow-up appointment, longer for a new patient appointment in face-to-face. And that is to enable distancing. Some of our clinics were face-to-face by default. So patients for acute transplant and patients with advanced CKD who are nearing dialysis. And each service had a generic email address. So transplantation, pre-dialysis, hemodialysis, well, hemodialysis, it would tend to be the dialysis units, but peritoneal dialysis, supportive care that patients could contact. This was established during COVID, but we've continued it as a point of contact for patients. And there are, you know, the email address gets checked regularly by a member of the team, and then either the messages forwarded on to a consultant or dealt with by the nurse, you know, the nursing teams as and when. In terms of dividing up between face-to-face and video or remote, there was no easy way of doing it, actually. Each clinician or group of clinicians, so for example, transplant, long-term follow-up, advanced kidney disease and so on, decided within their cohort how they would work within that system. So for example, there are some people who will say they will alternate a video clinic with a face-to-face clinic week by week. Some people say, okay, we are 3 consultants doing a low clearance clinic. We will rotate round and have 1 face-to-face and 2 video lists per session, and we will rotate who does that face-to-face and so on. So each kind of clinician group of clinicians decided how they would work in that system, bearing in mind the limitations in numbers of face-to-face. In terms of deciding who came to face-to-face, it was just hard manual labor is probably the only way of putting it. We were responsible for our own patients, and we would screen in the very beginning, you know, about relatively short notice, but kind of ideally up to a month in advance, but often it was just 2 to 4 weeks in advance. We would screen our clinics to decide who needed to come face-to-face and who could be seen remotely. That was the only way of doing it. Once we did that a few times, it then becomes a bit self-sustaining, in that you will have seen somebody once and then decide whether they need a face-to-face or a video appointment going forward. We didn't mandate how often somebody should be seen face-to-face or who has to come face-to-face, other than the acute transplants, obviously, and the people with very advanced CKD. We left that up to individual clinicians to decide. Because we'd just gone wholesale to video, and we sent all the patients a letter with information about how to log in, we'd recognise the fact that not everybody can have a video consultation, but anybody who didn't log in for a video consultation was telephoned. If a patient did phone up to say, oh, I can't use this, the secretaries would let the clinicians know and reassure the patient that they would have a telephone call. And then when that patient's appointment was rebooked, it would be rebooked as a telephone appointment. So we kind of started on one end and then worked backwards. The other thing that we did as well, in order to kind of streamline things, is that we've developed pathways for adding value to face-to-face appointments. So when you come for your face-to-face pre-dialysis clinic appointment with your advanced CKD, you will also see the surgeon for your pre-transplant assessment appointment. You might also see the nurse for your counselling, so that you've got more than one face-to-face consultation in one visit, basically. And that would minimise the frequency of attendances to hospital and the number of people in the department at any one time. Next slide, please. Concurrently with making this change, we also did quite a lot of work for data collection and analysis. And I guess the key thing is that there is no evidence that what we were doing before with having everybody coming face to face was better than what we are doing now. There is clearly a need for some people to come face to face. There is clearly a risk for people to come face to face as well. But in terms of outcomes and quality of consultation, as Hannah and Courtney pointed out, it depends on what you're trying to achieve. It depends on what the purpose of the consultation is and what the patient's, ideas, concerns, and expectations are. What we have done is we've developed a dashboard of all renal outpatient appointments, looking in particular at equity indicators. So looking at gender, looking at ethnicity, looking at age, and looking at index of multiple deprivation. We've looked at types of appointment by different demographics. We've looked at rates of attendance and DNA by demographic parameters. We're also now looking at 30-day admissions after appointments, comparing face-to-face and video, albeit that they're different types of patients, to see, whether there are any hard outcomes that we can look at with the change to video consultation. And those are kind of rolling ongoing analyses that we're developing. The other thing we did was we did not on your scale at all, but a patient and clinician survey satisfaction with video consultations, which broadly was very high, albeit with some caveats. We looked at people who DNA'd their video consultations, and we did a telephone survey where we called them up to try and understand the reasons why and go into a bit more granular detail. We've also created we have the KPA, and we take this work to the patient forum, where we update and we get feedback from the patient forum, which we now do via Zoom. But we also created a patient panel to inform the work that we're doing with regards to equity of access, and to invite them to come and, to share their ideas and kind of, consider them a test bed. And the idea of the patient panel is that it is as representative as possible of our patient population. So, for example, we've got people on there who are absolutely fine with technology. We've got people on there who are not confident with technology. We've got some people on there who are carers for somebody with cognitive impairment, and who is the usual point of contact, to try and keep as much of a breadth. We've got people who don't have English as a first language, to keep as much of a breadth of experience as possible on that panel. Next slide, please. So just a couple of examples of the work. I know I've got a couple of minutes, so I will speed up a little bit more. On the dashboard, we looked at, so this is looking at the proportion of renal outpatient appointments which were done remotely, which is predominantly video, but also telephone, from August to October 2020. Not much difference by gender. Young people more likely to be remote. Ethnicity, white and mixed tended to be more remote consultations, and then people who were most deprived tended to have more face-to-face appointments. Now, there's lots of reasons for that. Some of them will be clinical, and some of them will be related to access or equity issues. But what we did find is that there were significant differences by ethnicity and deprivation quintile in the proportion of attended renal phase appointments which were virtual, and the BAME groups and people in more deprived areas were more likely to be seen face to face. And these are also the people who were most at risk of coming to of COVID when they come to hospital. So there's an equity issue that was identified. Next slide, please. When we phoned our patients to understand why they had DNA'd remote consultations, lots of them identified process issues. So communication, didn't get the letter, didn't get their text reminder that they used to get about their appointment, forgot, that sort of thing. A significant proportion had a lack of access to the required IT or equipment. You could say yes to more than one of these, by the way. That's why it doesn't have to add up to 100. A significant proportion had a lack of knowledge, confidence, or interest in video consultations. And one of the things that I think came out in your survey as well, Courtney and Hannah, some people did not have a private space where they could have this consultation remotely. You know, they might be at work, or they might be in a home environment where the people, you know, other members of the family don't know about their health condition, or there was a need for a reasonable adjustment. So, for example, that could be an interpreter, or there might be a hearing impairment, and so on, and that wasn't available. When we took some of this stuff to our patient panel, they again brought up the need for flexibility in appointments. One of the things that they said is that, oh, if things are ticking along nicely, I'm quite happy with a remote consultation, but seeing somebody by video. But if there's something wrong, I actually want to come up and talk to you about it in person. That came across very, very strongly. The other things that they spoke about as well was the kind of social benefits of attending face-to-face. You know, if you are somebody, a couple of the patients who are quite elderly, who don't go out as much as they used to, they were like, oh, I actually quite like the trip into London. You know, it's a day, it's a day out. They'll come to their appointment and then they'll go and do something nice afterwards. So there are social benefits to kind of getting out of the house and being seen face to face. Next slide, please. So we thought about how we could close the gap. We have got a project running to call patients to offer digital assistance so that they can know how to use video consultations. We're training digital champions within services. So that would be the patient pathway coordinators, so that they can help facilitate, build kind of confidence in the patients with regards to remote consultation. Working with advocacy and interpreting services to facilitate better communication in identifying the need for an advocate. Interestingly, a lot of our elderly ethnic minority patients found it much more convenient to have a remote consultation, because a video consultation, because a family member could log in from home and join the appointment, and or log in from work and join the appointment. So some people found it an advantage, but not always. We are embedding some of these equity measures in our outpatient quality and performance metrics. We're also meeting with community groups to consider how we can provide hardware to enable patients to be seen remotely. Kind of video consultations seem to be far preferable to telephone consultations, so that's what we're trying to facilitate. And then the other things that we have now started to do is do focus groups with other patient groups, such as Deaf Plus, which is a local charity, to understand how we can meet the needs of these other demographic groups, such as those with particular disabilities. Next slide, please, which I think is my final slide. So my summary is that developing remote services very much remains a work in progress, and we've got no easy solution for triaging which patients need face-to-face and which can have a remote review. And I think it comes down to partly some clinician judgment and patient preference. That at the moment, with thinking about patient safety, having more people coming up face to face is not as much of a risk as it was in December or January. And so there is some flexibility when it comes to patient choice, but there might be situations in the future, if COVID was to resurge, or if there was another virus, where we do have to limit numbers again, and that will be a harder kind of context to triage in, and offer that degree of flexibility and choice. I would say that what we did was that we went backwards. So we went to kind of remote by default and identified those who needed to come up, rather than taking a patient list and looking at it and saying which of these patients could be seen remotely. We kind of went the other way. We think that there is an opportunity to more broadly evaluate our outpatient care pathways. So thinking about describing the kind of how we organise the service as a whole in terms of added value appointments, but also things like patient-initiated follow-up, which is one of the other things that we're going to explore for some of our stable patients in transplantation and in pre-dialysis. Buy-in from all the clinicians is essential, because it's the clinicians who know their patients best. That's easier said than done, but what tends to happen is if you can build a degree of momentum, then the rest will follow. Equity considerations are key, and that needs to be embedded in all aspects of service redesign and delivery. And as I've already touched on, patient preferences and expectations need to be balanced with the safety considerations, not so much of an issue now, but in the future, and done so in a way without compromising care. And I think that's everything from me.
That's great. Thank you so much, Sajida. That was a very comprehensive account of what you've been undertaking at the Royal London, with some really rich and valuable data, looking very broadly across the services. In the interest of time, I want everybody to know that we will be having breakout sessions where you'll be able to select which group you want to go into. So rather than providing Sajida with some questions now, if you'd like to quiz Sajida later in the breakout rooms, then please choose her breakout session. So moving on then, and we will move on swiftly in the interest of time to a talk on the self-care for healthcare professionals delivering remote kidney care. And this is from Amanda Bevan, who's the lead counsellor at Kent and Canterbury Hospital, and also Angela Taylor, who's the lead renal counsellor at the Sussex Kidney Unit. So Angela and Amanda, over to you, and thank you very much.
Thank you, Antonia. So Andrew and I are both presenting the self-care session. So what do we mean by self-care? Well, it's actually taking an active role in protecting one's own physical and psychological well-being and or health and happiness, particularly during times of stress. I have next slide, please. So just to give you some background in terms of how our counselling service has actually just changed completely overnight. From my particular experience, I came back from having a couple of weeks leave to starting back into the service, knowing that we were going to be stopping all face-to-face appointments. And fortunately, I don't know how quite this worked out, but because it never happens ordinarily, I'd actually booked an admin day on my first day back. So I came back in and was phoning for that day all of the clients that I had booked in for that week, just contacting them to find out or to share that we were not doing face-to-face appointments and we were going to work remotely, and finding out what sort of equipment they actually had. So whether we were going to be using their phone, a mobile or landline, did they have email addresses that we could actually send them links if actually they had devices that had a camera or speakers, and actually were they happy to use the video appointments. So I spent the day, as well as phoning people, actually collecting all my client notes and ensuring, because we were actually geared up to use what we had in place was the AccuX system. So we needed the patient's hospital numbers, the date of birth and their phone number, so that we could actually send out individual appointment invites each day to our clients. And this involved quite a lot of work in terms of our behalf. So I was quite grateful when later on, as the COVID pandemic went on, that actually we changed over to the Attend Anywhere system. So it involved actually sending out a single either text or video link to our particular clients, and actually, unfortunately, they had the job of putting in their name, date, and a phone number in terms of for them to log into the system. But actually, what we found in terms of other counselling services is that people actually didn't have access to either work mobiles or work laptops, and or they were actually, those items were shared amongst the team. So individual counsellors didn't have their own equipment. So we're using personal equipment initially, and in some cases, even a year on, they still don't have their own work equipment. So again, individual trusts didn't necessarily have different systems to actually work remotely using video links. So some counsellors were using Skype or even Zoom as a way of interacting with their clients and actually visually seeing them. The other consideration we needed to think about was about having locked cabinets at home and purchasing those, because ordinarily if I'm going to a satellite clinic, for example, I'll have my case that I'll put my notes in that are then locked in the boot of my car. But as we found out, that actually, that wasn't viable going forward, certainly for a year later. And one of the considerations, we'll elaborate a little bit more in the second part, but actually thinking about what space do you have at home to actually put your office space. And one of the recommendations is to not use your bedroom if you can help it, because again, you've got the element of potentially all of your clients sort of being in bed with you, as it were. So if it's necessary, if that's the only space that you have got, if you can try and sort of almost like convert an area within that space to make it look like an office space, so having a chair, and again, thinking about sort of backgrounds or backdrops. And we're already getting a bit of a taste with the different presenters that are on today, with the different backdrops that actually we can see behind them when they're working from home. So ideally, we're looking at having some sort of white screen or curtain or backdrop that doesn't give too much away about yourself and about your personal self. The other issue that we also ran into, which did prove difficult, was having translators. So although we could access them and include them in on the call, whether it be phone or video, the issue that we did have is that actually it wasn't the same person each time. So we would ring up ahead of the appointment time and find out who was actually working that particular day. We needed to build in time to actually explain to the translator what the session was about and what we actually needed from them. And sometimes some translators weren't particularly comfortable with the fact that it was going to be a counselling appointment, and it was something that they weren't necessarily that familiar with. And so we then might have to then try and ring around to get someone else and again inform them. So it was quite, it used up a lot of time trying to organise translators, but actually when it worked really well. And next slide. So again, this is thinking about our day-to-day lives are already stressful. And this was sort of pre-COVID, and if we add in the sort of COVID pandemic and the effects of lockdown and furlough, people working from home, actually homeschooling, that just increases a huge amount of change. And just thinking about the stresses then are all magnified, and hence why self-care is just really important. Next slide, and I'll hand over to Angela.
Okay, so I'm just going to talk for a moment about kind of what was kind of lost, what the changes were. And I think for many people during that kind of early stage, there was a kind of an inexplicable feeling of grief and loss that kind of accompanied kind of the lockdown. But that's kind of maintained a little bit throughout as well. And one of the difficulties for us in the work that we do was about kind of managing the boundaries of the work. And I found this really wonderful quote from Esther Perel, who's an American, Belgian-American psychotherapist. And she talked about the different aspects of ourselves. So the different parts of our identity. So we have a work self and a home self. And there was something about having to work from home that meant that actually our work self was lost. So she talks about working from home doesn't just mean a complete loss of boundaries. It means a loss of the routines and the rituals that used to help us kind of shape out our lives. And her description is, I get dressed for work, I walk to work, I stop and see my barista, oh, very nice. I enter the office, greet the doorman, say hello, put my food in the fridge, see if anyone's arrived. All of those things are kind of ritual behaviors that help kind of communicate to ourselves that we're now leaving behind our kind of home personality, that part of ourselves, and then we're entering into the workplace. So a different part of our identity is coming out. So our pre-COVID working lives came with all of these norms, rules, and obligations, but that we've lost those demarcations. And that loss, she describes, is part of why we're so exhausted and burnt out. And I think that's really important for us to kind of help manage that for ourselves, so that we can find ways of demarcating the different aspects of our personality and the different aspects of our day, so we can be really clear about what we're doing and when, so that we can actually feel we can let go of our work responsibilities when we're no longer in that work kind of headspace. But we have to kind of work quite hard to make that happen for ourselves when we're working from home. Next slide, please. Okay, so this is she's clearly my favorite, Esther Perel, at the moment. Really recommend her podcast. So making connections for us in our work is absolutely essential, of course. And we, like the Canterbury team, went pretty much working remotely overnight. So gathering ourselves in terms of what we needed for our work. And some of that work was on the telephone at first, while Attend Anywhere was kind of getting set up. But that was quite quick. We were, I think, one of the first teams within our trust to start using Attend Anywhere, and we all took to it and found it very valuable. But of course, you know, in this, it's really ironic in many ways. In this particular event today, I can't see people very close up. At the moment, I can only see 3 people on the side of my screen. Lots of people just have their names and not their faces. So that if we were all meeting in the same place, there'd be lots of kind of warm connections being made, either in the tea break or when we're arriving for the day, settling ourselves in. All of that kind of adds to our sense of ease, our sense of connection with each other. So for our sessions, this quote is really perfect in terms of counselling and psychotherapy work, but also for any kind of exchange that you've got kind of going on remotely with a healthcare professional. So we see each other and we're talking to each other and we're in dialogue, but I'm not making eye contact with you. Just to point out as well how strange it is that when you're using a screen, I'm not looking at the camera, I'm looking at the patient's face. So I'm not actually looking at their eyes. They're not looking at my eyes. They're looking at me, but not at their camera. So there's a real kind of strange disconnect that happens there. So my body is not registering. I'm not able to lean towards you. I'm not able to move away from you. And the entire embodied experience that you have in person is absent. We can have a conversation and it may become a very deep, rich, meaningful conversation, but there are elements of body language that can only be noticed when 2 people are physically present in a room. And I love this bit, an eyelid that just went up, a shiver. There are so many physical telltale signs that indicate that there's a difference between what you said and what you were really feeling. And this really picks up for me on some of the information that came about from looking at the differences between some of the patients' experiences of those consultations and some of the staff experiences of those consultations, in that there's a bit of a mismatch, not with everyone, but sometimes there's a sense when patients have, I felt like I was being rushed, or I needed this to, I knew that you know, they're very busy, they've got to get through a lot of people, so I may not actually say what I really need. And some of the medical professionals saying, somehow I sense that they weren't being truthful with me and they weren't actually sharing what was really important for them. And I think obviously that kind of stuff is so much easier to see when you're in a room with someone. When you call someone's name from a waiting room and you watch them walk around to the consulting room, you can pick up so much just from that exchange. So you're totally reliant on other ways of people being able to communicate with you. So you have to work a bit harder to get those little bits of information. Next slide, please.
Just conscious of time, Angela.
Okay.
To wrap up soon.
How long? Okay.
We're already over time.
Yeah, okay. Yeah, I was just going to kind of talk a little bit about a case study. Maybe it's something that I can talk about in the breakout room as well. But just to kind of acknowledge that that some of the work that we're doing is very intense, is very emotionally draining. And I think that, however, it is really possible to do some really, really intense and meaningful work with patients on a video call. And the case study that I was going to talk about in length, but we've run out of time, sadly, was about an end-of-life care case very recently. And I had the patient's permission to talk about it, and I may do in the breakout sessions. But it was actually a very intimate and very emotional piece of work, and not particularly task focused, but actually it was really a very amazing and profound connection that I managed to make with a couple, actually, with initially the patient and his wife, and he withdrew from dialysis. And we talked quite a lot about their plans and end-of-life care plans, and actually it was a very, very good experience of death, both for him and for his wife. And it was absolutely possible to do that really profound work working remotely, which I think beforehand, if someone had asked me, I wouldn't have imagined that would be possible. So it's important to recognize that there are some really valuable things that can come out of it, but it's really important that we look after ourselves when we come away from that very intense piece of work, and that we manage to take ourselves off for a walk just to ground ourselves and think about what we need. And maybe we'll talk some more about that in our breakout session. Okay. I'm aware of time, so. Amanda, did you just want to comment on that last slide?
Maybe more importantly, in terms of thinking about if people are going to attend our session, that actually if they could bring something that actually they can pop in their mouth. So thinking about taste, just for a mindfulness exercise, but we may or may not get time to do that.
Okay, so thank you both, Victoria and Amanda. Thank you. That's really so insightful, and it just shows some of the challenges, but also the opportunities that are available from doing video consultations and working remotely. I'm very mindful of time, so I think it would be a great opportunity to discuss those issues further in the breakout room when that opportunity comes up. So just moving therefore swiftly on to our last speaker for this session, I'm delighted to introduce Tahira Amir, who's a Cultural and Health Improvement Officer from Bradford Teaching Hospital, who's going to talk to us about supporting Black and minority ethnic patients in remote kidney care. Tahira, over to you, and thank you for joining us.
Hello, everybody. Thank you for inviting me. So my name is Tahira Amir, and I'm the Cultural and Health Improvement Officer, as has been said, for Bradford Teaching Hospitals. And just to tell you a little bit about how the role came about, in Bradford, they found the need to have somebody who could actually engage and communicate with a lot of our South Asian patients. And they were successful in applying for funding from Kidney Care UK. At the time, they were called the British Kidney Patient Association. So they originally funded the post for 18 months. And then the actual Bradford Teaching Hospital Trust realised the benefits of the role to the patients, and they decided to incorporate into the MDT team on a permanent basis, and not just to include the South Asian patients, but to include all the renal patients, and also to include social care work, because I was already doing that for the patients, even though it wasn't technically in my job description. So my job was to support and engage with the patients, their families, and the MDT team. And today I've been asked to speak about how I've been able to provide remote kidney care to our BAME patients. And I found that I've been able to do that quite well because I know the patients really well, and they know me, and we have that trust and communication and understanding between us. Because normally I would see perhaps a patient in the nephrology clinic or in the pre-dialysis clinics, and then I would follow them all the way through till perhaps transplant. So we get to know each other quite well. And because a lot of our South Asian patients and BAME patients felt that I was from a different culture, a different background. The South Asian patients felt that I was from their same culture and background, so they could relate to me better. And also other ethnic minority patients felt that because I was from a different culture, I could also understand where they were coming from. So I've continued to support the patients with their clinical issues and also with their social care issues. I work with, as I said, the whole MDT team. And so I partake in the telephone clinics and also the video clinics if the patients wanted to have an appointment like that. And also in webinar meetings, like for the young adult transition clinics, we use Microsoft Meetings, and you know, we ran those clinics, which the patients who were about to transition to us or are going to transition to us shortly found that really useful because they could see the team, they could see us, they could speak to us, and they were really engaging in that. I arranged with Kidney Care UK to be able to complete the grant forms over the telephone with the patients, and I was able to sign the form on behalf of the patients to eliminate them having to come into the hospital. And so that's been working really well. And I think, I'll give you just an example of this morning. I'm actually working from home today because I had a home visit to do in the morning, which we haven't done as many of since the pandemic, but we had a face-to-face home visit this morning, and then I had another meeting in the afternoon, and then this meeting. And because the meeting was going to go on for quite some time today, you know, I decided to work from home, and I have that ability to do so. But then I get emails and calls from the office. We had a particular patient who we saw yesterday in clinic, a transplant patient, who actually needed to be admitted today. And the team did call him, who's a South Asian patient who also has slight learning difficulties. And the patient and the mother asked if I could call them because they wanted me to explain things, firstly in their own language, and secondly because they have that trust with me. They wanted to explain exactly why he had to be admitted and what it all meant. So I was able to do that over the telephone, and they're quite happy to you know, listen to what I had to say, and they understood why he had to be admitted. And his mum took him to A&E, and he was admitted via that route. So my role is multifaceted, and I get involved with all sorts of different issues relating to patients. It could be medical, it could be medication changes, it could be checking whether the patient is taking the medication, or what dose they're taking. And because I can speak to them in their own language, it makes things a lot easier. I mean, earlier there was some talk about using interpreters, etc., and how familiar they are and how comfortable they are with doing certain types of appointments over the telephone. We're lucky in Bradford in the renal team that I am able to communicate with the South Asian patients, and because I do have the renal background, I'm able to explain things in greater detail to them. So it's not like a stop start like something said in English and then I have to interpret. I can actually explain it to them in a full sentence and with a flow so that they can understand the information. We've also done a lot of rather than home visits, we've done pre-education over the telephone, as well as call them into our unit, which is a green area. Now, when we're giving information over the telephone, say if we're doing like a transplant assessment appointment with a member of the transplant team, again, because they do know me and they have met me and they know that I understand them as a patient, they're quite happy to have the telephone consultation, and they do absorb the information in relation to transplant assessment. Obviously, we do see the newly transplanted patients face to face because they've just been transplanted and we need to keep an eye on them. And what my fellow participants have already said, sometimes you do need that face-to-face, and it is very important, and you can pick up a lot from a face-to-face appointment. But we have found in Bradford that the telephone appointments have worked well. Communication has been very good, and the patients have on the whole been happy with the telephone consultation. If they are experiencing symptoms and they do feel that they need to come in, they'll say that quite openly, and then they will be triaged and assessed, and a decision will be made as to whether they are, they do need to come in face to face to our unit. I think a few points on how to connect with the patient that I have found is that get to know the patient, the background, the culture, the religion, and say, like at the moment, if I was ringing a patient, and I mean, a lot of our renal patients would not be fasting through Ramadan, but if I'm speaking to one of their family members, they may be fasting. So say if I was doing like a video call, obviously I'm fasting myself as well, but I'd say to my colleagues, if you were doing a video call and they're not fasting, not to have, you know, a cup of tea or eat or drink in front of the patient while you're doing a video call, because the patient may find that disrespectful, and then that disconnect will happen. And we found that a few times. So little tips like that really help you to connect with the patients, because they feel that you understand them, you respect them, you respect their culture and their individuality. And also just to say hello in their own language really helps sometimes. So a lot of my colleagues have learned how to say hello in Urdu, Punjabi, and you know, for the Pakistani patients, the Indian patients, the Sikh patients, the Hindu patients, you know, they just, those little touches really help with connecting to the patients. The other things we've dealt with is a lot of patients like to speak to me about how they're feeling, especially during lockdown. So the other thing is to be able to listen. That's a very, very important tool. Just listen to the patient. And even if that is over the telephone, just to have somebody listening to them really seems to help the patient, because they can speak about what they're going through, and it makes them feel a lot better. Even though we're not face to face, they can explain to us how they're feeling, and we can advise them on different links that they could go on the internet if they're able to use the internet, and different places and different organizations where they can find help for their mental health issues. And obviously, you know, we have an organization like First Response if the patient is really suffering, and we do also have our psychology team that, you know, we can refer patients to. So I covered a whole gambit of information for the patients. I've also prepared a information sheet for the patients, which I can post out to them or email to them, detailing different organizations where they can obtain help. And naturally, during the pandemic, a lot of queries are related to being furloughed, benefits, entitlement, etc. So I do refer a lot of our patients to Kidney Care UK, who also work with a company called Origa, and if they feel it appropriate, they would refer them. So that helps the patients as well to have a one-stop shop and somewhere that they know is going to be able to help them with their social care issues, which is affecting a lot of our patients, as I'm sure you can appreciate at the moment. So, as I said, a lot of our patients have been okay with telephone consultations, and we have been able to continue to provide, as an MDT, as a joint team, the care that is needed for those patients. I mean, I deal with a lot of dialysis patients, and our dialysis unit is above, in the same building as where our office is, and I am able to go and see the dialysis patients face to face, but sometimes patients, you know, are not well enough to see us face to face, and because we want to reduce the footfall to the dialysis unit, I do telephone the patients. So I could be speaking to a patient who's on dialysis upstairs, and I'm based downstairs, but they know I'm in the same building, and if I needed to go up, I could go up and see them. But they've been quite happy to speak to me over the telephone, and for me able to sort things out for them via the telephone. Just to touch on a little bit about the other aspects that I do deal with live donor work as well, and also end-of-life care. And within the South Asian community, that is a very, very sensitive subject, as in any culture. But because I am from that culture, I do know how to approach these sensitive issues in relation to end-of-life care. And yes, it is more difficult over the telephone, and it's not ideal to have any conversations as such over the telephone. But sometimes the patient's family members have found it very, very helpful to be able to ring us, ring myself or ring the team, and actually speak to us about a family member that they may have lost. And they do find comfort in the fact that they can actually phone us, even though they can't come to see us face to face. So we are still able to provide that service to them as well. And we're there for them to listen to them. I could talk quite a lot about all the other different issues that I do deal with, but looking at the time, I don't know if it's a good time for me to stop. And then at the breakout session, if anybody's got any further questions, I'll be very happy to answer those questions.
That's wonderful to hear. Thank you so much. That's really insightful knowledge, and it shows the importance of advocacy and also trust, and the sort of nuanced delivery of that sort of trust that you can provide through understanding and having knowledge of the people that you're working with, which is really superbly important. So what we're going to do now is, shortly you will see on your screen an opportunity to go into one of 3 breakout rooms. The first is with Sajida to look at outpatient transformation and triage and communication. The second is with Angela Taylor and Amanda Bevan to discuss more fully self-care for professionals delivering remote kidney care. And also remember, Angela will take the opportunity to discuss the opportunities that she and her colleagues developed from working with a couple of end-of-life care and the success of that particular work. Or in room 3 to hear Amir and Fiona Loud, who will be joining her from Kidney Care UK, to talk through ways in which, at a national level, but also at a more local level, we can work to support Black and minority ethnic groups and other cultural issues when delivering remote kidney care. So Julie will put up those breakout room selections. Please select a breakout room and we'll reconvene in about 20 minutes or so. So a couple of minutes just to join your breakout rooms. And thank you very much again to all our speakers from this first session. Thank you.
Can I ask how I joined the breakout room?
Yeah, we're waiting for Julie. She is going to put up 3 options, should be joining our screen any minute.
Yeah, you should get a notification come up on your screen. I think if I stop sharing, you'll get the full access to Zoom, and you should get that link come up.
You can also join from the breakout rooms in the bottom of your toolbar.
Andy.
Yes, if everybody can see that on the bottom side of the toolbar, as Andy just marked out, you will go through an opportunity to join a breakout room. I honestly have no idea whether I'm in a breakout room or whether
You're not at the moment. You're not at the moment, Antonia. Teresa, are you able to put Antonia in a breakout room?
Yes, which one is Antonia in? Let me have a look.
I'm with Sajida.
Which is?
In the triage one.
Okay.
Breakout room 1.
Room 1.
So, could you put Sajida into that one as well, Teresa?
Yeah. Anyone else like to be allocated out?
Yeah, Sangala here. Can you stick me in Sajida's one?
I'm still in the main one, I think.
You are.
There you are.
We'll move you over. It's okay. We've allowed for time. So,
Julie, can I? It's Ed here. Can I go in room 1 as well?
Yeah, the triage one. Yeah. Okay.
Thanks.
Who was that? Sorry.
Ed Kingdon.
Ed. Yeah, you're going in 1. Okay.
And Sajida. Teresa, can you put Sajida in number 1?
Sajida, number 1. New triage. Yeah.
You should, Sajida and Ed, you should see something that comes up to say join the breakout room. So who have we got left?
Quite a lot, actually.
Okay. So there's somebody that says they're called Janet, but I've got a feeling they might not be called Janet. You're on mute. If you let us know.
That's
Nick.
Robert Lewis, our patient.
Yes.
For the next session.
Yeah,
Robert.
That's my wife's laptop, so I'm really not called Janet.
Have you got a preference?
No, I'm just listening in, so I'm not.
Okay, so what would you like to listen into? Would you like to listen into the triage or the supporting BAME or the self-care?
The self-care sounds interesting.
Okay. So, Teresa, that's the name that says Janet. Could you pop that one into self-care? Lovely, thank you. And Nick, I see Nick is still in this room. Can you put him into the triage? Nick
Thank you.
Yeah.
And you should see, Bob, you should see a notification that says breakout rooms, and it says you've been invited to join it. Just say join. Just click on join.
Okay, we've got.
Can I join the triage room as well, please?
Who's that? Sorry.
Yes, sir.
Yes,
Yes,
sir.
sir.
Where do you want to go? Yes, sir.
Triage room, please.
Triage. Okay.
Thank you.
We've got Victoria.
Yeah, Victoria, which route? Hello. Where would you like to go? You'd like to go into 3, the Bain one. Yeah.
Okay, there we go. Robert Lewis. Where would you like to go, Robert?
I think Robert would like to go in the triage. I believe that's. Did he say that?
Right, I'll do that now.
Sorry, I was on mute there.
All right.
Yeah, that's good. Triage. Good. Thank you.
Okay.
Thank you.
Nicola. Nicagati. No.
So let's have a look. So I think, would you mind putting Nicola into the self-care?
Okay.
Self-care is the quietest one at the moment, so maybe everybody who's left.
Benny M.
Yeah.
Self-care.
If you choose to go to another one, if you find yourself in a room you're not interested in, then you can self-select into one of the other rooms when you get there.
I think it's just you then, Julie. I think.
Yeah. Okay. I'm going to go then. I'm going to go into the AME one.
Okay. Are we still closing them at 16:45?
Yes, please.
Okay.
Okay. Thank you, Teresa. See you shortly.
Into patient view, and then I send an email to my consultant, and I basically give an overview about how I'm feeling, what my BP is, and I generally get to see my patient view results before the doctor does in relation to patient view. And what I find about that is actually I can look at that and I can monitor it myself, so I know where I am doing good and I know where I'm not particularly doing very well, or I know a reason why my bloods might be slightly different. We then have a telephone call, we have a consultation, we chat about it, and then that's really the consultation over. And I get a letter at the end as I would normally. So the consultant writes on aspects which we've discussed and talked about. So that's really just my experience. So, but I totally understand the comments and the aspects that were brought out before by Courtney and whatnot about how it affects different people, but that's just my experience. What I want to do now is just move on to these 2 different areas in relation to keeping patients informed and involved. But before I do that, I want to try and just explain a little bit more about CAPIN, and also try to let you know that there is something here that actually you might be able to help you. So it's something which we are here, we're offering help where we can. So The Kidney Patient Involvement Network, or otherwise known as KPIN, and once I finish my chat, I'll put these two into the chat room. Next slide, please. So we are a series of kidney organisations, charities and individuals who are looking at how we can improve patient and public involvement and engagement. We aren't the only ones doing it, and we're not proposing to be the experts at it, but we are there's a specific area we're trying to do with the patients that want to be engaged. We work together collectively on initiatives to improve standards, and what we're trying to do is develop patient leaders for the future. So we're just trying to help patients who want to be involved to be more involved and look at some of the aspects which they might want to look at. We also have professionals who are now involved as well. So when you consider COVID, a lot of the applications that we've made for help are very much based around research. So a lot of opportunities have come in around research, and we try and help the professionals as well in relation to their research bids. Next one, Julie, please. Small team. There's myself and you see there Holly, that we are the two that sort of again do it like a day a week. We've got Paula, who's also the co-chair, or the other co-chair of Tess, and then we have Nicola, who you're going to hear from not long after me. And that really is the core team. However, that core team is then supported by a patient advisory group, which is made up of patients from within the network, and also have a working group which it considers representations from a number of different organisations or individuals. Next slide, please. So the purpose, and I'll go through this relatively quickly, is increase the impact of patient and carer lived experience and the voice of that lived experience. We want to try and do that through meaningful involvement. We are looking to try and develop and embed quality standards of involvement for patients. And we are trying to create the network which really looks at the confidence, the knowledge, the empowerment of patients through research, quality improvement, and service development. We have a website. On that website, there is basic information, there's basic advice, there's guidance, and there's support. And because it's a group of liked patients, who are passionate patients, then we have this advice that we're able to share between each other. We've already talked about resources, for example, earlier on this afternoon, and we have a resource portal as well where we can either develop our own from patient experience, or we can link to other resources. And we offer peer support, and that's peer-to-peer support, patient peer support to another patient. Next one, please. So we have a website, we have all of the social media, Facebook, Twitter, Instagram, etc. We have a responsive database, so we have patients to become members and carers who become members of the network, and therefore we can then communicate with those through various opportunities that they might want to undertake. We put together development packages for patients and about their journey through their involvement. And as I said before, we have this support network for patients and professionals to share those experiences and discuss amongst each other. Next slide, please. So what we can offer you, or what we can offer the professionals or other patients, is that we have this network of patients. We have a membership of patients, and we are a community, not just a collection of people. We have the opportunity for opportunities to come into both either myself or Holly, and we are then able to seek patients that want to be involved in various aspects of either research, quality improvement, or service development. We also provided some training, webinars, and one-to-one training for patients and carers, and we link with and work with professionals to try and look at how they can engage patients in what it is that they are doing. So I suppose the ask from yourselves is, if you know of a patient who is keen to be involved, or would like to be involved, or is involved, and they want to become part of the network, we would like to hear from them. And equally, if there are professionals that are doing projects that they want to try and get patients from, we have a patient database currently of about 140 patients, 40 professionals. bearing in mind that we aren't after or wouldn't expect to get thousands of involved patients. Next slide, please. So why not contact us if you want to find out a bit more, and the details are on there, and I'll pop the details onto the chat once we start, without disturbing Nicola or Richard. Or Robert, sorry. Next slide, please. Okay, so Nicola and Shashi are going to be talking about a project which started, I think, before the pandemic, looking at trying to reduce the face-to-face appointments where possible, and clearly the unnecessary journeys. It's run in collaboration with Barts Health, NHS Trust, Kidney Care UK, and medical technology company, was that Cybert. I would also just like to pick up on one important aspect which I haven't mentioned, is the fact that the KPIN, Kidney Patient Involvement Network, is heavily supported by Kidney Care UK. Nicola.
Thank you very much, Andy. Oh, thank you, Julie, with efficient slides, efficient slide monitoring. Thank you ever so much. So thank you for the kind introduction. As Andy said, I'm Nikki Thomas. I'm a kidney nurse. I work at London South Bank University. I've also got an honorary contract at Barts Health. And my co-presenter today is Shashi Mataru, and she'll be speaking shortly. So as any project or good project goes, we always have a fantastic team, and I'd like to acknowledge the people at the bottom of the slide there. So we've had the transplant, the nurse, Mahalia Kasabar, renal physician, Dr. Raj Sirasingham from Barts, Fiona from Kidney Care UK, and two individuals from the company called Sievert, so Alex Blako, Chris Keneally, and also Nazrin, who was part of the Health Foundation evaluation team. So thank you to all of them. Next slide, please. So what I wanted to do first of all is to really talk a little bit about the challenges of remote consultation and refer you back to the national survey that we heard about earlier. So really, I've picked out 4 or 5 different things there, but what patients were saying was actually, when remote care started, there were difficulties in communicating changes in an individual's health, communicating the problems they were experiencing, how they were feeling rather than just the symptoms. Maybe it was a bit more tricky to be honest about how you were feeling as an individual, less opportunity for a conversation to develop, and difficult to discuss topics that were indeed distressing or causing fear, for example. Next slide, please. So as Andy said, we did actually start this project just before the pandemic. Some of you will know that the Health Foundation gives out quality improvement grants. We're not talking a lot of money, but it was due to be a year's project starting last January. It seems a lifetime ago now. But we did have the partners, Kidney Care UK and Barts Health, and as I've already mentioned, Sievert. So as you'll see from the slide, our initial idea was that we would work with Sievert, and they had a technology, a web-based platform that allows clinicians to automatically ask patients different questions via a questionnaire based on diagnosis and course of treatment. And so the idea is that an individual patient would receive this online questionnaire, they'd fill it out at home, and that information would then inform the clinician, alongside bloods and medication and whatever, about whether the person needed to come actually face-to-face for an appointment, whether they would have a remote consultation, or whether they didn't need to come at all. So that was pre-pandemic. So of course things changed in March. Next slide, please. So what did we do? So we focused on transplant clinic. Yes, next animation. Yes, thank you, Julie. I've already mentioned our project team, but we worked closely with a patient group, and we had individual patients who were from Kidney Care UK and also from the Trust. And what we did was we started with a validated questionnaire. Were there any questionnaires already out there that really asked people who'd had transplants about their condition, how they were feeling, their symptoms, all of those things? So next animation, thank you. So we did find one validated questionnaire, but it focused just on symptoms. It wasn't like an holistic approach to care. So we asked our patient group to review the validated questionnaire to add, remove items. Yes, next one. And then we went back to the clinical team, so the transplant team, and said, oh, you know, what do you think of this? And then the patient group tested the questionnaire using the CVERT system. So it was like a mock system. And then the patient group gave feedback, further feedback. And what we ended up with were 2 questionnaires. So these are people who've in receipt of a transplant, and it was either a questionnaire for a follow-up appointment, so maybe a monthly or you know, few weekly appointments. And actually there was a slightly different questionnaire for annual review. And next slide, please. And I'll come back to live testing in a moment, but what we did was, as I say, we have these 2 questionnaires. This is an example of the annual review questionnaire, and you'll see that there are different sections. So the first section is really about an individual saying, actually, what are my main concerns today? There is a whole section on emotional health, and that was missing from all the literature that we looked at. So we developed this whole section around emotional health. So as we heard from the survey earlier, people were saying, actually, we couldn't discuss emotional things. That was much more difficult remotely. So there are specific questions about emotional well-being, things to do with transplant failing. How do you have thoughts about the donor? That sort of thing. Next slide, please. And you can see that the different sections are the main problems: emotional health, physical health, and really what questions do you have? Actually, there is an extra bit on there, which is the last section will be, what do you feel? What do you feel that you need it to come up to hospital? Do you feel remote would suit you? Or actually, do you feel you don't need to have an appointment at all? Next slide, thank you. So what did we find? Well, after we'd developed the main questionnaires, we then had interviews with members of the patient group, and something we were particularly interested in was added value. What difference does this system have over ordinary, let's say, remote consultations? And these were some themes that came up. It was this idea that it was now a partnership. It was about empowering people to ask questions, to talk openly about their feelings. There was something about speeding up communication, possibly between primary care and secondary care. Patients would have more time to think. Here's a quote. I think it was really positive. A lot of thoughts being put into it. The questions are clear. I think the questions are easy to understand. And actually, we're hoping to involve some self-management. So it will be a two-way thing. So somebody might, for example, put in their blood pressure or their urine test, and there can be discussions around that. Next slide, please. So now we're going to hear from Shashi. So very nice to meet you, Shashi. I know we haven't really met we haven't met in person, but I know we've had remote discussions. So I'm so delighted you could take part today. And Shashi is going to concentrate on those 2 questions. So what matters to you with respect to remote care, and then something specifically about the added value that this project brings. Thank you.
Well, when I first did this survey, I was interested in like the results of the outcomes of the whole questions and how remote consultations and that would work. And I thought it was a good idea, but I think the idea is good, but putting it into practice hasn't been as good. My personal experience, it started off okay and it's got worse. I mean, okay, before there was no COVID, but obviously COVID hasn't helped, but it feels like COVID's taken over everything and nothing else kind of matters. So even getting a GP appointment is a nightmare. Even booking it online can be a nightmare. It takes you around in circles before you get anywhere. When you are trying to get hold of your kidney team, finding appointments, you're expected, you get a letter saying you're talking to your kidney consultant, and then that never happens. And even down to your blood tests. Now I was getting regular blood tests, and now I haven't heard from them for ages. And I think that's not just me. I've spoken to a lot of transplant and other kidney patients that I keep in touch with, and we're all experiencing the same things. And I know you can find out your results online. Obviously, some people have a problem, and I've had a problem actually logging into mine, and it's taken me 5-6 attempts for them to actually get that right. But even the layout is it's not the best. I saw everything I wanted prior to my EGFR, which is the main thing I wanted to know. If you got any questions, you have phone numbers you can ring. Nobody ever answers. Leave a message. Occasionally somebody rings back. So I think in practice it's not working. But I'm glad that you guys are doing something like this. So maybe, hopefully, the feedback that you get will show that they need to kind of do something about it. I don't know where anywhere else is working in the UK, or how is it working in like Manchester or London, but in Birmingham, I don't think it's working. And I actually think that's really bad, because I would love to I'd love to do a Zoom meeting with like my doctor, and, you know, stay at home, wouldn't have to go all the way into Birmingham and, you know, pay for parking, and I'm happy to just do it online. But now and again, if I need to go in, that's fine with me too. I don't have an issue with that, but it's actually trying to sort it out that's the problem. And I don't know how many people are experiencing the same things.
Yes, thank you. I mean, as Fiona has mentioned earlier, you know, the surveys are showing this, all the different issues with, you know, not individualised care, difficulty accessing the healthcare team, not getting answers, not being timely, integration of blood results. I mean, that, you know, that those things we really need to tackle. In terms of this idea of filling out a questionnaire before you potentially either come face to face for an appointment or have a remote consultation. I mean, what do you think about that? I know obviously you've been involved with this study and developing the questionnaire, but generally, I mean, maybe you could tell the audience, you know, what you think about that.
The questionnaire was all right, but the thing is, so you got to go deeper. I mean, it tackles some of the areas, but then some of them you have to go deeper into it to say why. And a lot of people, it depends who's doing the surveys, I guess. But a lot of people don't want to put all these things down. I think if it's a one-to-one, it's easier, I think. I mean, like with my medication, I find sometimes my hands start to shake, so I get put off writing it. So I'd rather be more verbal, because then it can come across better.
Yes. Shashi, you may have seen that we've only got a minute left. So what I think we can do is I'll have my next slide, and then we'll pick all these really important points up when we have the discussion. Okay. So thank you ever so much. But I just need to finish and say really what's going to happen next. Well, actually the project is pretty much finished. We've given our report to the Health Foundation. We're still hoping to do live testing, like a pilot with 5 people at Barts. And we're going to be thinking about developing this a bit more. So a triage, thinking about a two-way conversation. So if somebody asks about, you know, I don't know, blood pressure or medication or something, then the clinician will be able to respond. And the whole business of linking blood results. We absolutely need to do further evaluation. And just to say as a final point that we're very happy to share our methods and questionnaires with other trusts. I think, Julie, I did have another slide, but maybe just quickly show it and then we'll finish. Yeah, just to say, I mean, what Andy's already said about KPIN, I'd really ask people to reflect on that questionnaire we heard at the beginning and see, you know, how well you're doing. Start early, anything like this with information governance and ICT teams, and pin down evaluation and sustainability plans. Thank you.
Thank you, Nicola. What I'd like to do now, I think if we're getting a little bit shorter for time, is move on to Dr. Robert Lewis and Dr. Nicholas Sangala with a patient, Robert Lewis, going to talk about a web-based app, My Renal Care. So, Robert, do you want to take it?
I don't know whether you can hear me or not.
Yeah.
Okay, well, I don't know whether the video is coming up as well, but thanks everybody for asking us to come along. Now, we're from the Wessex Kidney Centre, which is a big transplant unit, does about 100 transplants a year, covers 2 million population. And my colleague, Nick Sangala, who's on the call at the moment, invented something called My Renal Care, and he's developed it. Now, you might think he's the exact person that you want to give this talk, but of course, he'll be terribly enthusiastic, and whatever he says good about it, you'd say, well, he would say that, wouldn't he? So instead of that, what we've got is me, and I'm a crusty old nephrologist, been around for centuries. I'm completely tech not savvy, and I've been using this. So in a way, it's a much better description of what it's for. And then at the end of this, we're going to hear from, curiously, the same name as mine, Robert Lewis, who's a patient of ours with kidney disease, who's been using it. So hopefully you'll get a nice spread of opinions about this. Can I have the next slide, please? So the first thing is, why are we even talking about virtual healthcare? Well, just to throw our minds back to the NHS plan, which had these various sentences in it about over the next 5 years, patients will have a right to a digital sort of health service, aiming to avoid unnecessary outpatients appointments. And that's really what triggered this innovation, which started way before the COVID crisis. But we also know, don't we, from our own experience, sitting in an outpatient's clinic, some poor patient has come many miles to come and sit in our waiting rooms, waiting an hour to come in to hear you say, well, your creatinine's stable and your blood pressure's fine, and then get back in their car and drive away, which isn't a good use of anyone's time, which is what really initiated this. And then on top of all of that, of course, came COVID. Could I have the next slide, please? And we've heard what COVID did. And what I'm hearing from the talks we've had before is this sort of unplanned, almost like a panic of what are we going to do if we can't see people. But what's interesting, if you notice that people have tended to retain their usual working practices. So in other words, we still have clinics. And then what we do is we might have a video consultation or a telephone call instead of seeing them, but it's still in the context of a clinic. But is that really the best way to deliver healthcare? That's the question I'm going to hopefully answer for you. Let's have the next slide. Right, so what do we mean by virtual consultations? I just need to tease this one out. You'll hear people talking to about virtual clinics being the ones where a GP sends like an advice and guidance to a specialist and they decide whether they need to be seen. Well, I'm not going to address that in any great depth. That's advice and guidance. Then we've had a lot of what we've heard about, which is the scheduled remote interaction with patients, either by video or telephone. But I put it to you that, in fact, actually, what we ought to be going for is guided patient self-management. Now, I'm sure I'm not alone in having patients that have had a transplant for 30 years, still have a creatinine in double figures. And you think of all the knowledge that they've accumulated over that time, why aren't we utilizing that in the context of their care? And you'll see again from the NHS long-term plan, we want people to have more control over the care they receive and actually to look after themselves to a large extent and actually assist carers in delivering their care. And we'll call that guided self-management. So that's what we're going to try and do with this innovation that I'm going to describe to you. Let's have the next slide. So we looked at our outpatients appointments, and this is, I'm sure this is the same in every hospital. This is a table showing the number of appointments per year for patients. And if you look at the green section there, those are patients that have come up 4 times in a year to be seen. Now, these people are all coming for routine monitoring. These are our transplant patients who've got stable kidneys, but are compelled to come up to have the routine check. And you'll see that about, well, in our department, 86% of the patients were coming up for that sort of a consultation. Now, I don't really think that coming to the hospital is necessarily the best way to look after these people. So have the next slide. So we've developed this app. Now, let me just explain it to you. It's a web app, which means it's available on the internet from anywhere in the world. And the patient downloads this onto their computer or smartphone. And then we then work together, and the green dots there show the routine care that we might want to offer. So if I just explain it to you, I might say to a patient, well, let's see you let's review the situation in 3 months' time. So I then set a date which they have on a diary on their smartphone, which is in the app. They then undertake home monitoring of their blood pressure, symptoms, or whatever it might be, to their own satisfaction. So they can do that as frequently as they like. Now remember, this would be time when they wouldn't be being seen at all in the hospital, and yet we're recording that information. More to the point, they can actually see whether it's a problem, because on their app is a management plan which includes what their blood pressure should be, etc. And they might want to initiate a contact if that exceeds the target they've been given. But let's suppose that they're nice and stable. We then come round to the time in which they're due for their review. They have a stack of forms for blood tests, and they can go somewhere convenient to suit themselves when they have that blood test done, which might be at the GP or at a local hospital. That they then notify the clinician that they've had it done, and the clinician then gets an email to say the patient has had a blood test. You can look at the blood test. You then take the opportunity to look at all the blood pressure readings that they've done over the intervening time, and then you upload some feedback onto the app saying everything's fine, and then you set another date for the next review. And at no point are you actually in physical or auditory contact with the patient. They look after themselves. Now, importantly, none of these things have to be done at a given point in time. So it means that I get an email, and over the course of the next day or so, when I've got time, I will respond. I will put something onto the app. So I'm not tied down to 5 o'clock or 3 o'clock on a Wednesday afternoon. Also importantly, you'll notice a little arrow there saying PIFU, that's patient-initiated follow-up. If a patient feels that they do want to have contact with you outside of the set time, well, then they can just put a thing on the app, which will come to me as an email saying I need to have contact with you sooner. Or they can, if they're worried about something, if they've just had a urinary infection, they want to do an extra blood test, they can put that on themselves and even look at the result. And then up the top left-hand corner, you'll see that there is a way out of this cycle of routine care, which means that if anything goes wrong, so for instance, if the blood test is not satisfactory or the blood pressure is not satisfactory, I can then initiate a telephone or face-to-face consultation. So it means they can step out of this when the need arises and be seen or spoken to, so they're not stuck in cyberspace. Next slide. So what comes out of this is a new way of working. If you look at the bottom part of that slide shows what we used to do, which is every 4 months or so, just see someone, and it would be just in case. So someone's got a transplant, they had their renal function done 4 months ago, and now you're going to do it again and see whether it's any different. But the whole intervening period, you don't know what's been going on. Whereas in the top, we've got these little micro consultations that we can use. So if, for instance, the blood pressure is a little bit high, I might want to initiate some treatment, and then I don't need to see them again. I just want to see that the blood pressure has responded. And so I can quickly look into that on the app and check everything's all right and send a note to say everything's fine. So it's a completely new way of working outside of a clinic. Next slide, please. Importantly, what do patients think of it? Well, we took the time to ask people before starting this what patients would feel about remote monitoring. And remember, this is before COVID. And on the left-hand side, there's a little pie chart answering the questions. What are your thoughts on virtual clinics or using an app when you're feeling well? And to our surprise, 82%, as you can see, said tick the box that said monitoring my kidney condition is better done remotely. Now, we accept that this is a selected group of people, but it shows that there was an appetite for this sort of offering even before COVID and before we put it into place. On the right-hand side, you've got a pie chart of has your feeling of involvement in managing your renal health changed since using the app? This is after 6 months in 100 patients, admittedly selected patients, and you'll see that they either feel much more involved or slightly more involved than they did, or as involved. And only 3%, that's 3 patients, felt less involved. So from this, we take we reach the conclusion that this is a good answer to the unnecessary coming up to hospital. Next slide, please. This speaks for itself. We asked the question, would you recommend using My Renal Care to other renal patients? And I don't know why the slide didn't come out with that, but that's 3% of people said no, and 97% of patients said yes. Next. So we have to say that the patients that used this were a self-selected bunch to a large extent, because we restricted it, of course, to people who had internet access, and restricted it to people who wanted to do it. Those are the only 2 criteria we used. So we said, we've got this thing, would you want to try it? And of course, that would then self-select a subgroup of people. And much is said about health inequalities. But it's important to emphasize that just because something is not perfect and isn't applicable to everybody doesn't mean to say that it doesn't have value. And we accept that in order to use this, you would need to have the right sort of physical abilities, language skills, and you need to have access to the internet, which might disadvantage some people. And of course, the clinicians themselves will tend to offer this to people who they think can do it, and the unreliable people that they don't trust, they probably wouldn't ask. So all of those caveats need to be acknowledged, but they need to be put in context. I don't know whether you saw on the news just yesterday, actually, that since COVID, it's currently 6% of households do not have internet access. So we're talking about a vast majority of people could use something like this. These are ONS statistics here that show that 91% of adults between 25 and 64 are regular internet users. They all use Amazon and online banking, etc. Even in older people, 80% of people over 65 use the internet. So most people have this capacity. And of course, if they don't want to use it, they don't have to. The choice is the most important thing. But we have shown that people do choose to use this, and those that do choose to use it have good reports of how it's been for them. Can you have the next slide? Next slide. So what needs to change? Well, unfortunately, we live in a world of doctors who insist on having evidence, because everyone's got an example of what they did to try and do remote care, but no one's ever shown in any rigorous way how good it is. And RCTs, which are the backbone of science, really I don't think really apply very well to this sort of thing. We want to be looking at patient-reported outcomes, etc. And we want qualitative research, but we do need to have some evidence to show that this is suiting the people that we look after. We also need an adaptable workforce. And consultants, as you may or may not know, are hidebound by job plans that say that you have to do a clinic at a given time during the week, and then you'll get paid a PA, as they're called. Well, as I've explained to you, if we're doing this throughout the week at opportune times, depending on when our patients need us, then that isn't going to work. So we need to adapt the way that consultants work. And we also need responsive commissioning, because how do you pay a hospital for providing this sort of service? It's not a clinic, you know. Is it a consultation? Does a micro consultation cost the same in a tariff as an outpatient's appointment? So someone's got to integrate this sort of way of working and buy into it with new ways of commissioning. Have the next slide. That's really what I want to say. I mean, you think how the NHS is run at the moment. We've got vast databases full of patients' information. We've got appointment systems that are all run on computers. And yet there's been a complete failure to grasp the potential that IT can give you for actually giving patients access to this and helping to look after their own care. I often make the analogy between your health and your finances. The fact is that well, you know, if I was to say to you that your bank account was a little bit like an experienced transplant's blood test, and I said to you that you can only find out how much money you've got in your bank account if you make an appointment to have a video consultation with me in 3 months' time on a Thursday, you'd be a bit annoyed. What we've got here is a way that they can access that immediately. And that's the way it should be. And the computer could say, yes. Well, anyway, that's me as an old crusty old git using it. What would be really interesting would be to hear from my namesake, Robert Lewis, who's a renal patient who's been using it, and we'll see what he says. And I don't know what he's going to say, so it better be good. So next slide's for Robert.
Yeah, hello. You'll have gathered by the fact that my name says Janet on the screen, that I'm not technically savvy either. So forgive me for that. Thank you for the introduction. As I say, my name's Robert Lewis. I'm a patient under the care of Queen Alexandra Hospital. In November 18, I was admitted to the renal department, diagnosed with vasculitis, chronic kidney disease. After a couple of weeks, I was discharged and commenced regular weekly visits to the clinic. For a while, I was asked if I'd like to try the newly developed My Renal Care app and possibly provide feedback. I found the app to be very easy to use, informative and beneficial. Its contact. I would describe the app as being very interactive, and as a result of using it, I've developed a weekly routine of adding the app, my blood weight, urine test results. It helps to give me a sense of being a little in control of the health. It's a really feeling, but it makes you feel involved. I have blood tests on a monthly basis and have the confidence of knowing that I will see the results the same day, along with comments, instructions regarding medication, advice from my consultant. At no time did I feel isolated or insecure as a result of using the app in addition to contact. In fact, to the contrary, I felt more secure and involved. Then, of course, along came COVID, so face-to-face contact stopped altogether. Virtual talk over, but worked just as well alongside the app. The app has a facility called the non-urgent contact request, which we actually affectionately call the panic button. I've used it several times to seek advice, but last November, I felt that something wasn't quite right. I just wrote a brief outline of how I felt and submitted this information. Within 10 minutes, my consultant was on the phone to me, instructed me to go for a blood test locally, and arranged for me to be admitted to hospital. In fact, the same day. It was, in fact, a relapse with my condition. Now, this fast response helped to reinforce my confidence in the app and made me realise its true value. I do appreciate it wouldn't suit everybody, not all patients, especially older, less technically able people. But it'll become more valuable as time goes on, because tomorrow's patients, today's youngsters. My 10-year-old grandson could find his way around his dad in half. It took me. And just to finish, if any other renal units should adopt this app or any other platform similar, I'd be only too pleased to make my contact details available to any patient who might need advice about using it or have doubts about its value. And I think I've really summed up the app, and you'll realise that I think it's an absolute fantastic thing. So I think I now need to hand back to my namesake.
You. I've finished everything I wanted to say. I think that's the end of that particular session. I don't know whether Nick's got anything he wants to add or whether he wants to wait until the breakout.
No, over to Antonia.
Okay.
Andy, sorry.
Okay, so I think we are going to actually move, not going to do questions now. We can do those within the breakout room. So the same thing from last time. There'll be 2 breakout rooms, and you can have a selection of which one you would like to go in. You'll get a 2-minute identification. It's going to close, and then we'll all come back to summary at the end.
Okay, thank you. I'm going to stop sharing my screen, and you should be given the option of your breakout room to attend. Fantastic.
Julie, it's Nick Sangala here. I just don't know how to get into the room. Can
Okay.
you stick me in the My Renal Care one?
Brilliant. Teresa, could you move Nick into My Renal Care, please?
And same with me, please,
And,
Rob
and
Lewis.
Robert. And Robert
Julie,
Lewis.
it's Ed Kington. Can I go into the My Renal Care room as well, please?
Yeah.
Julie, it's Antonia. Can I go into the My Renal Care group as well, please? It's not allowing me to.
Okay.
Yeah, it's Fiona. Same here, please.
Okay. You should get a thing pop up inviting you to join.
Julie, was that Robert Lewis wanted to go into My Renal Care?
Yes, please. And Fiona and Ed Kingdom.
Ed, yeah, okay. Okay.
And Shashi is in the Shashi is in the involving patients in follow-up one.
I better go on that one actually. Sorry.
Yeah, so Fiona involving, yes, Shashi and Fiona in involving patients in follow-up. That's the first room. Victoria, which one would you like to go to? The first one as well. So again, involving patients in follow-up for Victoria.
Let me just move Fiona. I've got to find her again.
Okay.
Fiona's going into involving patients, yeah?
Yeah.
Okay.
So I'm here twice. So just move both of me. And one of me will, I'll log out one of me in a minute. Beg your pardon.
I'm sorry.
It's too complicated to explain why.
That's okay.
So I've got... Oh.
But mobile and not mobile.
Yeah, that's okay.
So I've got Victoria.
Victoria wanted to be in the involving patients.
Okay.
As I said, again, if you get into a place that you don't want to be in, you can join the other one.
Yes.
So, Sajida, have you got a preference? Sajida, so I think anybody that's left over, would you put them all into the involving patients in follow-up one, please, Teresa? And if you end up in a room that you don't want to be in, please move yourself into the other one. I'm going to go to the involving patients one now. Teresa, thank you very much.
Gosh, we could have had more time in that renal care app. I don't know about you.
You absolutely could. Julie, could you put up the final slide for us, please? Thanks very much. Do you think most people are back in the main arena now? Yeah. Okay. So my sincere thanks to all of you for coming today to our delivering remote kidney care workshop and how to optimise the way in which we deliver remote kidney care. I hope you've enjoyed our session where we've heard some superb information from the national survey presented by Hannah and Courtney, and then 2 key sessions looking at how healthcare professionals can help to practically implement and deliver remote kidney care with attention to detail on self-preservation and well-being, and also diversity and inclusion, and also some really innovative new ways in which we can help involve patients improving their lived experience of remote kidney care and novel technologies to help us improve that. Just with regards to the next step for this particular session, there will be a page on the Renal Association website, shortly to become, of course, the UK Kidney Association, where all the resources and a recording of this session will be available along with some notes from today. And the link to that will be sent to all delegates as soon as it is possible. We've realised through doing this programme of work, along with our mini workshop series we had before Christmas, just how complicated delivering remote kidney care is, and how utterly important taking on board the patient lived experience of receiving kidney care absolutely is. And so I'd encourage everybody to really take account of what they've learned and heard from these experiences. We will, we hope, be continuing to run a programme of quality improvement initiatives through KQIP, looking at various techniques. So if you become something novel, or we could update people on the way in which the delivery of remote kidney care is continuing, we want to hear from you, and we want to share this information, importantly, with everybody in the renal community across the UK Kidney Association as this work evolves. So thanks once again. We'll close there and we'll be in touch, and we look forward to perhaps seeing you at our next remote kidney care optimising delivery and participation in remote kidney care workshops, and indeed masterclasses in due course. My thanks again to all the speakers, and special thanks to Julie, Leanne and team at KQIP, who worked tirelessly to pull this together to deliver you this on a remote platform. Thanks, and have a lovely evening, everybody.
Thanks, everybody. Take care. Bye.
Bye.
Thank you all.
Julie, are you doing the debrief on this one?
I don't know. Am I doing the debrief on this one? I thought we had a different link.
Oh, have you? I'm just going to have a look. Sorry, Antonio.
Yeah, there's a different link.
Is it a different link?
Okay, I'll close this one down then.
Yeah, I think there's a different link.
Okay, thank you. Bye.
Bye, everyone.